Hi there! My name is Student Nurse Amber, and today I will be discussing information and demonstration of the assessment of the thorax region, including the lungs. It's part of a comprehensive assessment or a focused examination in the respiratory system. Our thorax region is between the root of the neck superiorly and the abdomen inferiorly. But please note that we're checking this region anteriorly and posteriorly. Although thoracic assessments are often conducted as part of routine physical examinations, this assessment is also important to diagnose or monitor certain medical conditions relating to the respiratory system's organ and processes. So, what are the things that we need to prepare for this examination? And what are some special instructions that we can request from the client in order to properly accomplish the assessment? First, we will be needing a stethoscope to listen for breath sounds in the lungs. Number 2, it is best to use a chair without a backrest since the patient needs to be in a sitting position so we can access both anterior and posterior sides of the thorax region. A chair with overlay table in front of the client will be used in the assessment of the posterior side later on. An appropriate lighting is important so we can appropriately inspect the client. Draping is another important consideration for this assessment, most especially if the client is a female. We have to ensure that there is appropriate covering for her breast area for privacy. But a gown with open back is essential for both genders because chest should be fully exposed as we examine it. The 4 basic techniques of examination will all be used in this assessment, and it should be done systematically or chronologically to avoid discrepancies or disturbances in the course of the assessment. So, we're starting from inspection, palpation, percussion, and lastly, auscultation. Now, before engaging with my client, I have to make sure that I did a proper hygiene. I will now introduce myself to the client and explain the reason for the physical assessment. I will also need to verify the identity of the client using 2 identifiers before proceeding with the next steps. Additionally, I can explain to the client that the examination may take a considerable amount of time to perform and also the ways on how he can help me during the process. Alright, let's start. Hello, sir. My name is Amber and I will be your student nurse for today. How are you, sir?
I'm fine.
Okay, and can you please state your full name?
My name is Diego Ramos.
And when is your birthday, Sir Jago?
My birthday is on October 22, 2005.
And can you tell me where you are?
I am at a clinic, I suppose.
What brings you here?
Well, I have been feeling too tired lately and sometimes I catch my breath after walking for a few minutes.
I see. I'll take note of that. Okay, so today I will be doing an assessment with your respiratory system, and that includes your lung region. Okay, in doing so, I may need you to follow some instructions. It's just minimal. I'll ask you to walk around or stand up and raise your hands or bend. But I'll be also exposing this part of your area. But don't worry, sir, because I'll be closing the windows and the curtains to maintain your privacy. Is that okay with you, sir?
Thank you, Goa.
The reason why we're asking a series of additional questions is to assess the client's cognitive status. Through this, we will be able to check if the patient is alert and oriented. This can quickly give us an idea about his general neuro status. Now, after gathering the subjective part of the interview, I will now dive deeper into the assessment of the posterior and anterior thorax of my client. First thing that I'm going to do is to observe or inspect the back or posterior side of my client. In inspecting, what I'm looking for is symmetry, observable deformities, masses, swelling, and shape of the thorax. As I inspect the shape of his posterior thorax, I made a visual measurement of his postero-anterior and transverse dimensions to get a ratio value. The normal is 1:2 ratio, which is what my client has. I also noticed that the posterior thorax and lateral sides are bilaterally symmetrical without any notable elevation or depression and deformities. There is also no wound lesion or redness around. Therefore, my client's thorax from posterior and so in his lateral sides are so far normal. Now, I'm also observing the spinal alignment for deformities. So, I ask my client to stand up straight, and from the lateral position, I observe the three normal curvatures, which are his cervical, thoracic, and lumbar. To assess my client's lateral deviation of spine, I stood up behind him and asked him to stand up straight, straighten his hand, and bend forward, reaching his toes. As he does that, I observe that he does not have any delineation in his vertebral line. After informing my client that I will start palpating him, I immediately assess for the status of his skin temperature and the integrity of all his chest skin. So far, he has a uniform temperature, intact skin, no bulges, tenderness, or abnormal movement in any areas that I palpated. Important to note though is that we should avoid deep palpation, especially if the client just had surgery within the area or has fractured ribs. Deep palpation could be very painful for the client. To check the thoracic expansion of my client, I place my palms over the lower thorax with my thumbs adjacent to the spine and with my fingers stretched laterally. Then, I ask my client to take a deep breath while I observe the movement of my hands. In deep inspiration, what we're observing here is for my thumbs to move apart at an equal distance at the same time laterally. Normally, a distance of 3 to 5 centimeters or 1.2 to 2 inches is considered normal. Next is to check the posterior thorax for fremitus. Fremitus is a faint, perceptible vibration that we can palpate through the chest wall when a client speaks. To start the examination, I place the palmar surfaces of my fingertips or the ulnar aspect of my hands on the posterior thorax starting near the apex of my client's lungs. Okay, Sir Jaga, please say blue moon.
Blue moon.
Okay, can you say one more time? Say blue moon.
Blue moon.
Alright, another one.
Blue moon.
Alright, great. I compared or checked if there is a bilateral symmetry of fremitus on both lungs and between the apex and the base of each lung. In the apex side of the lungs is where we can feel the strongest vibration. One thing to note here is that low-pitched voices of males are more readily palpated than the higher-pitched voices of females. Let's move on to percussing the thorax. Through percussion, we can penetrate up to depth of 5 to 7 centimeters or 2 to 3 inches to detect superficial rather than deep lesions. The corresponding examination is done to determine whether the underlying lung tissue is filled with air, liquid, or solid material, and to determine the positions and boundaries of certain organs. To start, I will now ask my client to bend his head and fold his arms forward across his chest. This way, both scapulae can separate a bit further, giving the lung tissues more exposure during percussion. Once there is more open area where I can percuss, I will locate the intercostal spaces starting at the axilla and working down to the 8th rib at intervals in a systematic sequence. What we're trying to hear is the resonating sounds during percussion. The three specific sounds that can be heard are resonance, dullness, and timpani. In the lung area, as should be, we are more hoping for resonance sound, which could indicate airy and light hollow organ. Please note that the lowest point of resonance is at the diaphragm area, which is at the level of the 8th to 10th rib posteriorly. For the last part of the assessment on the posterior thorax, I will be auscultating the diaphragm using my stethoscope's diaphragm side. It's best to hear high-pitched sounds like breath sounds using that instead of the bell side. So, I ask my client to take slow, deep breaths through the mouth and then listen at each point of the breath sounds during a complete inspiration and expiration. The normal sounds that we are looking for and comparing both lungs are vesicular breath sounds and bronchovesicular breath sounds. I'm glad that I did not hear any abnormal crackles, gurgles, friction rub, or wheeze during my auscultation with my client. Let's start the assessment on the anterior side of the thorax, similar as the chronological order of techniques of inspection, palpation, followed by percussion, and lastly auscultation. First, I took the liberty of getting my client's respiratory rate without his knowledge. I did not inform my client that I'm counting his breaths to avoid manipulating his normal breathing. As I navigate my eyes through my client's chest area, I also observe that the rhythm of his breathing is normal. It has a regular pattern and I'm not seeing any shallow breathing or any sign that he's catching up on his breath, but instead, he's showing a nice deep respiration. This is evident on my client's posture as he is sitting instead of leaning forward. Second, I observe the costal angle, which is the angle between the costal margin inferior to the xiphoid process. Normally, it's about 90 degrees. An abnormal finding is when the angle flattens out or whitened. This happens with chronic lung conditions like emphysema, among many others. Good thing is that my client's costal angle is normal. In the third step, I will start palpation. Same as what we did on the posterior thorax, I'm checking for the uniformity of his chest skin's integrity and temperature. Similar results showed that he has a uniform temperature, intact skin, no bulges or tenderness, or any forms of abnormal movement in any areas that I palpated. Checking the thoracic expansion of the anterior side is also similar to what we did on the posterior side. I've also placed my palms over the lower thorax with my thumbs along the costal margin under the xiphoid process this time. Then, I ask my client to take a deep breath while I observe the movement of my hands. Alright, Sir Jago, please take a deep breath. One more time, please. Nice and easy, deep breaths. Alright, one last time. Perfect. We're also listening for fremitus on the front side of your thorax. For female clients, sometimes if the breasts are large, there's a possibility that palpating the fremitus on the anterior side cannot be examined adequately. So, this part of the examination is usually omitted. In step 6, I will start to percuss the anterior thorax of my client. I started above the clavicles in the supraclavicular space and then proceeded in a downward path to the diaphragm. Again, the 3 normal sounds that should be present are resonance, dullness, and tympany sounds. Resonance is normally heard down the 6th rib, but there could be flat sounds over areas of heavy muscles and bone. Now, the dull sounds can be normally heard over the heart and liver region. Tympanic sound, on the other hand, is best heard normally over the underlying stomach. We should compare both lungs as we do the percussion on each side. For female clients, we can displace the breast to facilitate percussions of her lungs. Onto the 7th step and the beginning of my auscultation, I will start listening to the trachea of my client. This region is where we can only hear the normal bronchial breath sounds. What we should hear is a high-pitched, loud, harsh sound created by air moving through the trachea. For the last part of my examination, I will now start auscultating the anterior thorax. So, I ask my client to take slow, deep breaths through the mouth and then listen at each point of breath sounds during a complete inspiration and expiration. Again, we are trying to hear and compare both lungs for vesicular breath sounds and bronchovesicular breath sounds. I got the same result from the posterior thorax, meaning no crackles, no gurgles, no friction rub, or any sort of wheeze during my auscultation in the anterior thorax. Now, don't forget to document all findings on the client's record. Also, make sure to let the patient settle down a bit after a long and thorough examination. Thank the client for his complete cooperation, entertain any questions related to the assessment, and do a proper hand hygiene after interaction with the client. In summary, a focused thorax assessment of the respiratory system is very helpful in examining the current respiratory status of a client. Respiratory rate is a fundamental vital sign that is sensitive to different pathological conditions. Breathing and breath sounds, on the other hand, is as important in providing clues associated with the body's ability to obtain adequate oxygen and nutrients, and that is paramount for a person to perform his or her daily functions. Having a regular assessment can monitor our lung health or track any changes or progression in respiratory conditions or identify potential complications early on.